Hello, my name's Tudor Oman. I'm one of the Paediatric Emergency Medicine Consultants in the Royal Belfast Hospital for Sick Children. I've been asked to talk to you today on paediatric cardiac arrests and maybe give some of my tips in this field. I do recognize that this audience is probably quite a mixed group, with some of you only starting off in your training and maybe haven't had that much exposure to any arrests in children. However, I know that there's probably a lot of you who are battle-hardened pros who have seen it and done it all, and nothing's going to faze you. However, I must admit that I haven't met anyone who hasn't let out a little wee when they hear the pediatric arrest bleep go. I'm hoping to have something for everyone here. From a statistical point of view, there's no way that I can compete with adult medicine in the volume of patients that you have probably seen in cardiac arrest, and that's just down to statistics. Pediatric cardiac arrest is quite a rare presentation, but can be quite specific in its cause and different in its causes to adult arrest. So without further ado, we're going to move into the statistics, and as usual we break the statistics into pre-hospital and in-hospital cardiac arrests due to the difference in presentation and CPR delivered and management. So out-of-hospital cardiac arrests in adult, it's estimated about 70 per 100,000 per year is the number. And when we look at children, that's all the way up to sort of 18 years old. There's 7.2 to 11 per 100,000 cases a year. So quite small numbers. It is a rare presentation. Of those, there's a very small amount that is caused by traumatic cardiac arrest. And a study in 2017 showed that analysis of the TARN data in relation to cardiac arrest in children due to trauma, well, there was only 15 cases, which accounts for about 0.6% of the TARN data. Now that's a very small number. I'm sure over the recent years with the increase in knife crime that we've seen that this number is now increased, but at the minute it's still small figures. Most of these are not going to be shockable. Only 7 to 10% of out-of-hospital cardiac arrests are due to VF or VT, the majority being asystolic arrests, and that comes down to the etiology of pediatric cardiac arrest, and we'll talk about that in a minute. Within this age group, there's stratification of risk as well. So less than 1 year old is the majority of patients that we see in cardiac arrest, and they have the poorer prognosis as well, with only 3.3% of them surviving to discharge. The second peak we see is in adolescence, and then middle-aged children between 1 and adolescent age being the least affected. And their survival rates indicate that as well. So there's better survival in children, and then teenagers, there's another dip in survival. Survival with no neurological deficit is also very poor, and we'll talk about this. Often out-of-hospital cardiac arrests can be unwitnessed, and they can have a prolonged no-flow phase, which results in poorer neurological outcome. So survival with no neurological deficit is around 0.3 to 4% in out-of-hospital cardiac arrests. What contributes to survival? So as I said, short no-flow stage. The no-flow is when there's no circulation occurring. So bystander CPR has been shown to be very important in the management of out-of-hospital cardiac arrest to reduce that no-flow stage. Ventilation, and I mentioned this, and I'll mention it later as well. Ventilation is very important. Adults are moving to chest compression only CPR in the community due to the etiology of adult cardiac arrest, but ventilation is very important in pediatric cardiac arrest. ROSC return of spontaneous circulation before arrival in ED is a good prognostic indicator. Shockable rhythm, and also adrenaline. So adrenaline is a bit of a questionable topic here. A Paramedic 2 study came out showing that those in out-of-hospital cardiac arrests that received adrenaline had a more returned to spontaneous circulation. However, the neurological outcome wasn't as good. We haven't extrapolated that data to pediatric studies as yet, and there are some studies that show children who have early adrenaline in in bradycardia with shock in hospital have poorer prognosis than those that don't get it or have returned to circulation prior to receiving adrenaline. Either way, there's not enough evidence to make a decision on adrenaline in pediatric cardiac arrest as yet, so the algorithm still stands. We follow the APLS guidelines. Adrenaline should be given in pediatric cardiac arrest. In-hospital CA is about 100 times more common than out-of-hospital cardiac arrest, with 1 to 6 per 1,000. And a majority of these, a lot of these, about 2 to 6% of these occur in PICU admissions. And this is common sense. You've got children who are admitted to the hospital because they're unwell, they've got comorbidities, and therefore they're a higher risk population already. 71 to 88% have pre-existing conditions, and ROSCs are achieved in 64% of those, with a better survival of 12 to 25%. It's still poor, but it's better than the out-of-hospital cardiac arrest. And that's also sensible because you have monitored environment in which quick, effective CPR should be able to be provided. And these children often have better neurological outcome. Again, only 10 to 14% of these are shockable, the rest being asystolic. I've kept etiology to the end of those two groups rather than separating them because it's similar in in-hospital and out-of-hospital cardiac arrest. Most children progress to cardiac arrest from a respiratory or cardiovascular failure, leading to hypoxia, hypocarbia, increased acidosis, hypotension, eventually impaired cardiac function, and then asystolic arrest. And this is the usual pathway that children follow, and therefore treatments need to be aimed at trying to minimize these and deal with the hypotension and the hypoxia that they're experiencing. So, as I've mentioned, there's different phases to cardiac arrest. There's pre-arrest, there's no flow, low flow, and post-arrest. Okay, no flow where there's no movement of blood in the body, low flow when CPR is commenced, and post-arrest. I'm not going to talk about post-arrest very much here, but if I had a further point to make here is that as I was going through my training, it was all about trying to get return of circulation. We worked hard in a cardiac arrest to try and get that, and very little thought was often put into the post-cardiac arrest management. And what I would say, if I had another point, was to ensure that while you're going through this, you're preparing as well for success. If we don't prepare for success, then what will happen is that the child will get ROSC and over time may drift back into cardiac arrest again, or have a worse outcome, neurological outcome, because you weren't prepared for that. And Dr. Canaris, who's teaching on this course as well, has written an excellent article on post-cardiac arrest management, which you should read. So I won't take his thunder. So my first pearl. Now, please don't go to sleep on this, all right? It's not what you probably all want when you come to an emergency conference, but I think it's highly important. Prevention is better than cure, and we need to look at this in our pediatric population. I'm sure in adult population similar issues are there, but in prevention in children, as a pediatrician, that's one of my responsibilities, to look to see what I can prevent happening so that I don't have to deal with a pediatric cardiac arrest. And in hospital, one of the things that comes across and has been extensively researched is the use of early warning scores. Now, in our hospital, we use early warning scores. These show you the trend of observations a child who has been admitted is having, and gives you early warning that something is not right, either a persistency in a tachycardia or increasing oxygen requirements. And that score then gives you an alert, the nurses an alert to say either increase the period of, reduce the period of observations or get a doctor to see, and allows you to consider early intervention in preventing this child's decline to cardiac arrest. And when you look at the etiology of pediatric cardiac arrest, most of these are progressive conditions. They are declining over a period of time, and if you can pick that up early enough, treat your hypertension, treat your hypoxia early enough, you can prevent this child stepping into cardiac arrest. Along with this goes education of staff to recognize key features in history, examination, and also observations to prevent missed cases. And when we look in our department at serious adverse incidents over the years, those that were missed often had predictors in their history or in their observations when they were discharged. For example, a common one would be a persistency in tachycardia, an unexplained tachycardia, and then they come back either in cardiac arrest or severely unwell. And so therefore we tell our staff that they are not able to discharge a child with abnormal observations unless there's a good reason. For example, you've had them on salbutamol inhalers and therefore they're tachycardic, but there's otherwise well. But if you are unable to explain abnormal observations, then a senior needs to see them or they needed to be admitted for observation. So I think this is key in prevention of pediatric cardiac arrest. We deal with a population where the signs of cardiac arrest can be seen in most cases and prevented if we are observing them well. I also have the privilege of working in a department that is has a very good public health involvement, and we run a number of different campaigns. So we see a lot of SUDIs, sudden infant deaths, in our department each year. And this last year has been particularly bad. And educating the public on safe sleeping patterns and safety with children in general can reduce the chance of seeing babies coming in dead to your department. I think we all have a role in that. If we are seeing severe conditions coming in with decline that result in cardiac arrest, death, or increased morbidity, then we have a responsibility to look at how we can prevent that. And sometimes it's about doing the work with Public Health Agency and bringing awareness to the public. Other examples are button batteries, the recent increase in magnets and perforated viscous due to magnets, residential speed limits, car seats, seat belts. These are all campaigns that have reduced traumatic cardiac arrest, traumatic or other causes of cardiac arrest in children. Carer education comes into this. An admission to hospital is an important time to teach parents what to look for in decline in their children when they go home. In our department, we emphasize every child who gets discharged should be told what signs they are looking for deterioration in their child, and if any of these occur, to come back to our department. So parent education is key, and part of that is doing CPR training. And there have been studies showing that children with chronic conditions who have received education and basic life support actually do better in cardiac arrest because they get early intervention at home. So those who have out-of-hospital cardiac arrest with chronic conditions actually have a better survival. Bystander CPR is very important, and that comes down to public involvement and training and availability of AEDs. So survival with bystander CPR, you get 9.4% out of hospital cardiac arrest versus no bystander CPR at 4.7%. This comes down to a reduced no-flow stage. And if you have a look at the statistics, if you wait 1 minute before starting CPR, you're providing about 20% of normal cerebral blood flow. If you wait 9 minutes before CPR is commenced, you have no flow, cerebral blood flow. And the outcome is a lot worse. So early intervention with bystander CPR is important. Now, children have less bystander CPR than adults do, and this may come down to the fact that most pediatric cardiac arrests occur at home, and therefore in an unwitnessed or have limited supply of people who may know CPR, and that's where parent education comes in. My second pearl is about providing early, good basic life support. And there's good evidence to show that if you provide good basic life support in children, that the outcome is better. So you get higher survival, you get better neurological outcome. But evidence is also there that shows that even in hospitals, even in pediatric hospitals, we provide inconsistently good CPR. And it's up to the team leader during a resuscitation to be brutal about pulling up people who are not providing the correct chest compression, both the rate and the depth. And there was a study done in an intensive care unit showing that regular short periods of simulation, just giving real-time feedback on depth of compression and rate of compression, improves survival of the patients. And the importance of this is depth of compression. You're not going to get flow if you're not pushing hard enough. Rate of compressions, if you go too slow, you're not providing enough circulation for the brain, and you're not providing enough coronary circulation. If you push too hard and too fast, then you're not allowing full recoil of the chest, and you're not allowing time for the coronary arteries to perfuse, and therefore this can actually be detrimental to your resuscitation. So effective high quality CPR is key. And my second point, the main point I want to make, is that running regular simulations with your team, teaching them the depth and the rate that they should be doing chest compressions will improve your outcomes from your CPR in your department. And I'm trying to instigate that in our A&E department with regular interval training on both bag and mask ventilation and chest compressions to ensure adequate basic life support. So debrief is also very important after post-arrest to ensure that learning comes from it, but my main point is made. My third one is tied to that. Ventilation. Now, as I said, adults are moving towards chest compression only resuscitation, and that's because the etiology is different. You have an arrhythmia, you suddenly collapse. These people are not generally hypoxic initially. So the etiology is different. In children, you have hypoxic or circulatory collapse, in which there is a low oxygen store in the body already. Children have a higher metabolic demand and increased oxygen requirements. So therefore, this is the reversible cause in initial cardiac arrest in children. So if you do not provide ventilation breaths, you're not going to get anywhere with your CPR. So at the minute, standard BYSTANDER and out-of-hospital cardiac arrest still recommends providing ventilation breaths to children. I've got in here oxygen, no air. Neonates use air due to the risk to the premature brain. Due to the hypoxic nature of pediatric cardiac arrest, it's still recommended to use 100% oxygen during your resuscitation, but maybe in the near future, we'll see some more studies coming out in the concentration of the oxygen we provide during our resuscitation. The main point I want to make here is that there's been studies, it's a question I actually get asked a bit by ambulance crews, is should we intubate or not? And evidence has shown that bag and mask ventilation is as effective at providing good CPR to the good resuscitation to these children, and that intubation in inexperienced hands can actually lead to prolonged delays in providing effective basic life support. So my recommendation is that unless you are experienced and you know that you can intubate this child quickly, if you are getting good chest lift and you are able to ventilate this child, bag and mask ventilation is your tool of choice. There are some papers that have indicated that intubation in hospital results in poorer prognosis of children. And again, this may be because of the delay or the pauses in attempting intubation with delay in providing chest compressions. So if you're getting chest lift and you are able to bag that child, then bag and mask ventilation, unless you are an experienced operator, should be your choice in ventilation. Remember that we're all panicking a little bit, or we all feel stressed in a pediatric cardiac arrest, and over ventilation can be detrimental to your patient. One of the indicators for poor prognosis is persistently low CO2 in a child. So if you are over bagging, and I know I have a tendency initially, and I have to check myself when I have an arrest situation, that I am bagging at the right rate. All you're trying to do is lift the chest. You don't need to over ventilate them. So just be aware of your bagging skills and how much you are providing. And this comes down to training again, and should be regularly simmed with your team. My last point is more about when to stop resuscitation. And I know as a pediatric trainee, as I went along, you're involved in a resuscitation, and the fear of missing something or not doing something that could have reversed the situation leads you to going into prolonged resuscitation. And I remember prolonged resuscitations as I waited for a senior person to come in and make the decision to stop resus. And this is my word of the day. I don't even know if I can pronounce it properly. Dysanthesia. And this is prolonged resuscitation just to preserve life with no real benefit. Okay, and therapeutic perseverance or medical futility are other words that you can use. And this is when treatment offers no hope of recovery or improvement, or for which the patient is permanently unable to experience the benefit. And more we're looking at neurological outcome for these children. And prolonged resuscitation, even if you get ROSC, often leads to a poor prognosis with a severely disabled, neurologically deficit child, or someone who then later progresses to further cardiac arrest later on. Factors which may influence your decision are the cause of arrest. So if there's a massive traumatic cardiac arrest, which is not compatible with life, or there is an underlying medical condition that the outcome is not going to be good, these are indicators that maybe your resuscitation attempts are futile. Whether it was witnessed or unwitnessed, as I said, reduced low flow states, a no flow state is a better prognosis. Prolonged no flow has poor outcome. Bystander CPR, duration of CPR. So it is thought that if you have asystole and you have no reversible causes identified, if you have resuscitated for 20 minutes or more, then the outcome is not survivable. The initial arrest rhythm, as said, VF arrest is got a better prognosis, although in children we see mostly asystole. So my experience is that I've seen more children recover from an asystolic arrest, but that's just statistical. If you look at the outcomes of VF arrest, there are more chance of survival if you have a reversible cause. Change in rhythm from asystole to VF gives you something to treat and has a better outcome. Persistently low ETCO2 I've mentioned. Reversible causes. If you've run out of reversible causes and the child is still in arrest, then the outcome is poor. I put in here echo, and there's been a little bit of research in looking at cardiac standstill on echo. I like a bit of point of care ultrasound, but the evidence is that not great for making a decision on cardiac arrest, stopping cardiac arrest based on cardiac standstill. 14% of adults who had cardiac standstill progressed to have recovery of circulation. And therefore it's not currently recommended in medical cardiac arrest. However, in our traumatic cardiac arrest algorithm, it is there as part of your decision-making tool. If you see cardiac standstill and you've done all your surgical procedures to try and return circulation, then echo can help you make a decision to stop. If you have standstill, futility is there. Premorbid conditions we've talked about. And then when definitely dead. As I've mentioned, we see a lot of SUDI cases coming in, and often these cases, these children have been dead for a while, and they arrive in with CPR ongoing. They have rigor mortis and pooling of blood. They're cold, and at this point, resuscitation is futile. So early cessation of CPR is beneficial, not necessarily looking specifically at the child at that, but trying to take your team through a resuscitation that everyone knows is futile is not good for the team morale in that respect. So there are times to continue resuscitation. VF arrest is one of those, and you can get this electrical storm that you may need to continue resuscitation until you've dealt with all reversible causes and given a chance for that to settle down. Hypothermia, such as in your drowned patient, is an important time to continue resuscitation, and the saying is that you're not dead until you're warm and dead. Sometimes this can be difficult to call, but that is the general rule. In asthma, you get this hyperinflation due to air trapping, and so resuscitation should be continued until you're able to decompress that chest a bit and allow circulation, because you get this effect of tamponade on the heart with these hyperinflated lungs. toxins are an important cause of pediatric cardiac arrest, and if there's toxins related, there's evidence to show that prolonged resuscitation can result in good return of circulation and good neurological outcome if prolonged. So the decision to stop resuscitation is the team leaders. I have to emphasize it is not up to the parents. The parents are emotional, they have a lot more riding on this, but it's a medical decision to make. Don't ask the parents whether you should stop. It's not their responsibility, it's your responsibility. It doesn't have to be a responsibility that you bear alone. You have a team there, and I would often discuss termination of care with my team, highlighting what we have done, the things that we have reversed, and the length of resuscitation that has gone on before I make that decision. You need to continue CPR until you feel like you have enough information to make that decision. So initially when they come into the hospital, you often don't have, and you may need to do a round of CPR just to get a hold of all the information that you need. Each case is individual, but prolonged resuscitation can be devastating, have devastating consequences if return of circulation and the child is significantly neurologically knocked off or has a later cardiac arrest and death can be traumatic to the family. And in all of this, don't forget your team. This is traumatic to the team as well. And post-arrest debriefing, both hot and cold, have been shown to improve outcomes for future resuscitations and also help with team mental health. So in summary, I'm not the guru here. I'm giving you my thoughts on cardiac arrest, but prevention is better than cure. High quality CPR is key, and practice that over and over again with your team. 4-yearly APLS doesn't provide enough practice for that. Children need to be ventilated, and bag and mask ventilation is as effective in the untrained, instead of intubation if you're not trained specifically for that, and know when to stop. So that's it, guys. Any questions?